Welcome to my program. I can't remember the last time I made a flipper, also known as Anterior Resin Reinforced Bridges, sponsored by Denture USA. Disclaimer: the only financial conflict in this program is Denture USA is providing support for the continuing education credits that are being supplied to the participants. Participants should be cautioned about the use of limited knowledge in anything they do in clinical dentistry. As you can see, this is the only altered photograph in the entire program. Did anyone actually notice that I was missing an eyebrow? All right, so here we have this drives home so many points. One is you've got a young individual who's 14 years old, has completed orthodontic treatment, and now he's referred back to you or the general dentist for his implant. Well, there are so many red flags. He's 14 years old. Home care is lousy, but when you look at that cuspid in the number 11 area, you can sort of see from the angulation, well, that apex is going to be right over here. And then you've got the central, which is off. So if you would look at an X-ray, they sort of converge right in that one spot. So you're going to be pretty limited in placing an implant. The other factor is he's 14 years old. His face hasn't matured yet, and things are going to change. 6 to 11 pretty much stays in place, but the bicuspids and molars seem to grow, and his vertical dimension is going to change. His smile line is going to change. So I'm a little weary about putting an implant in somebody that really hasn't matured yet. And now we have the finished product. So what I've done is I bonded the lateral, the peg lateral that you can see with straightforward bonding. And I took a good old-fashioned denture tooth. I made a little ridge lap area that you can see to give the illusion of it growing out of the gingiva. And on the lingual, I had a little bit of space, so I didn't even have to really put any class 3s in the adjacent teeth. I just used a micro etcher and I just roughened up the lingual surface, and I put a little bit of material. At this time, it was a denture tooth with a material called Rib-Bond, and then we had to replace that because Rib-Bond has its own problems where it wears over time and looks like a wet dish towel that's in the back of the patient's mouth. So here we have the before and after on the left and the right, and we have a really good result when he's 14. And I'd like you to think outside the box. You know, it's one of those things, 50% of the dentists that graduate from dental school never change. And I'd like you to just have an open mind, listen to the program, and maybe incorporate a little bit of this into your practice when you get back to the office either tomorrow or next week. Bar. I mean, I'm dating and I'm aging ourselves, Joan and Mike and everybody else, because I haven't heard this phrase in a long time. I mean, that goes back to 1972. 72, a periodontist named Zisa, his last name was Zisa, invented the Bar. He's a small company that he still manages to sell and share that. This is the real one. That's what a Bar looks like. It almost looks like a railroad track that we would put between bicuspids and then lay some composite. And they were strong, but they were ugly as hell. They just really were ugly. All right, how familiar are you with a product called Rib-Bond? So let's go back here. Let's launch that poll. Rib-Bond. You're currently using the material. I've used it in the past. It may ring a bell, or you're not familiar with Rib-Bond at all. So I really need to know, because this gives me an idea of how many were using this material and using the concept of reinforcing their composite with that. So let's end this poll, share the results, and a very small percentage, and Rib-Bond has its flaws. 60% have used it in the past, a quarter of you sort of know what it is, and 12% don't know anything about Rib-Bond at all. Rib-Bond was the initial company that claimed to have fibers that you can embed in composite to act like rebar and reinforce your composite so that it would be less prone to fracture. And if a tooth did break off, it didn't fall completely out. It just sort of hung there like a hangnail. And a patient said to me, you know, my front teeth are loose. And I said, let's get an X-ray. And then she says, I don't think we need an X-ray. I said, what do you mean we don't need an X-ray? And she reaches up into her mouth and she pulls her 2 front teeth out. And they were splintered together by these 2 crowns. And she would literally take these teeth and put them back in and then do her business and function for the day. And when she went to bed at night, she'd take them out and she'd put them in a glass. And so, you know, when I used to get that call, my receptionist would say, we got a loose front tooth. You just had no idea what to expect. Here's another patient with a loose front tooth. This is a young woman. This goes back to probably around the late 1990s. And she's got a fistula. She's got a fistula over a very common problem where you get these narrow endodontically treated teeth, a cast post, and they fracture. They fracture. So she had a fractured root. She's got some crown and bridge here. She's got one natural central in the 23 area, and she's trying to start a family. So it's pretty hard to sort of explain that, we need time for healing and we want to do this stuff, and find out that she's going to get pregnant. But what I did is I took a good old-fashioned denture tooth, which happens to bond really well to our current composites, put some fibers on the back of it on the lingual, did not have to prep. If you notice, there's no preparation at all on the lingual of 23. And look at the bone. That's without grafting. That's without anything being done other than the denture tooth being put into place. So we went from this tooth with a huge fistula and bone loss to this right here where it's sort of leveled out. And I was taught in dental school that if you cantilever a tooth off, you'd end up with a vertical defect. And you should see a vertical defect going down that PDL. But you can see this is stable. Clearly, I've taken it out of occlusion, and when she goes into excursions, she doesn't hit the tooth. But it's now lasted quite a while. And this is what it looks like clinically. So here you've got 23, which is the natural tooth. This is a little denture tooth that I modified. You do have to modify the ridge lap area, which is no big deal. It's like doing a denture repair. You just roughen up the ridge lap area. I put a dimple in it to just express some material into the dimple and lock it into place. And then you take your good old-fashioned monomer or your bonding liquid and you sculpt it into place. And a lot of times what I'll do is I'll squash it down over the healed ridge if it's healed, and then I'll just get rid of the flash and then bond it in place. So there's the open view. There she is when she smiles. She also happens to have a cantilever here. So cantilevers are working out well for her. And it's been in the mouth now for over 20 years, and I've never had to touch it. When I was opening my practice back in the early 80s, in the dark ages, we used to have TMS pins, if you remember TMS pins. So I started off splinting with TMS pins, then I went to Ribond. But look at this perio. Look at this perio here. So this is in 2011. This photograph was taken. So I probably did this initial splint when I took out that tooth around probably 1985. And now this is 2011. There's her smile. She wears a partial, but that's what it looks like when she's not wearing her partial. You can see that I've adapted it well to the ridge lap area, and the lingual's nice and smooth. Since that X-ray that you saw, I have taken out the TMS pins. They tend to cause shadowing and a little bit of discoloration, so I just grind it out, leave the tooth in place, and I fill it in with composite. I like the idea of a composite reinforced material. I like Dentapreg, and there are some competitors out there from GC and some other companies. But what's nice with this material over Ribond, it's actually composite. And I'm gonna let the chemistry and the explanation go to Danik when it's his turn. But the stuff is so thin and so flexible. But when you touch it, it has that air inhibited tacky layer to it, and you know it's going to stick to the composite when you put it on. When it comes out of the package, it's got two layers and it's sandwiched between them. So I take my perio probe or a piece of tin foil, I measure the length that I need, I cut it with a scissor, and then I spoke to them and I said, what you need is a light box, just like you would for X-ray film or regular film. And they designed a little tiny black coffin. So when you're done with this, you can put this thing in a little tiny black coffin, close it up, and it preserves it so it doesn't set. So the bottom line is it chemically cures to all the composites that you're using. There are no voids in it, and there's no area of weakness. So here's that same patient that was 14 with the missing lateral. So now he's close to 19. Home care is pretty much still the same. You can see his smile line. There's the denture tooth. And on the back of it, there's Ribond. So initially I used Ribond, and you could see right where my cursor is over time, since the teeth were not prepared, and it's literally paper thin, what's happening is the Ribond is now exposed. And he wasn't really complaining about it because I guess it was a gradual process over time. But when I did my exam, you could see the fibers are now exposed from the Ribond. So what I did is I went back and took 558 burr and just removed the Ribond. I didn't remove the tooth. All I had to do was remove the Ribond matrix that was there. It's very easy. You feel like you're cutting tissue paper. And then I would go ahead and I put the Dentapreg material as a replacement in, and then covered it with good old-fashioned composite, smoothed it out, and then polished it. Now here he is. Now he's in his 20s. So this is a kid that started off when he's in his 20s. The bonding on the peg lateral. Home care is a drop better, but certainly not where it needs to be. But you can see how the gingiva is reacting to that ridge lap area. And now he's in his 20s. Joan, I probably should have worn black. This color is, is just, I think I look thinner in black, but things have changed a lot since then. But he's also, he was a little kid when he was 14, and now I've aged as well as he has. Now, interestingly, this is just another one of those orthodontic situations. So this was referred to me by an orthodontist, and what happened is he had an impacted cuspid that they tried to bring in, and then eventually gave up. And they gave up, and then they just said, all right, the orthodontist will make space for an implant. Well, the kid is 14 years old. And not only is there not enough space for an implant, now he had to show it when he smiles. So what I did is I just took a denture tooth, and you don't even have to prepare it. So this is actually on the left where my cursor is. That's a bicuspid. And then and then I've got a lateral. So what I did is I just took a denture tooth, thinned it down, adapted the ridge lap area to it, and then on the lingual just floated in. There's no occlusion on it, so there's just no preparation needed. And the mother was thrilled because now she went from thinking that her kid is going to be mutilated and traumatized for the rest of his life with surgeries that he's going to have to deal with, and now he's got a simple solution that he probably won't have to deal with, if at all, until he's in his 20s. And if he has to, he can just rebond it. So here's a typical case of a perio case that I was maintaining over time. And he ended up in a full denture, but just before I made him the full denture, you can see probably the best 3 teeth in his mouth where the splint was done with my denture tooth and the resin bonded splint. So he had that done. But this is a very common scenario. For some reason, these laterals go south. Here's a perio defect. He's got a failing endo tooth. I extract the tooth. The nice thing about the extracted tooth, and I'll go into why I don't use the natural tooth. So in this case, you're never going to use an existing crown. You'll never be able to bond well to it. But I don't use the natural tooth because the bond strength to a regular composite denture tooth that you buy from your lab or from your dental supplier is so much stronger than you can get to enamel. And if I do see a failure, which happens rarely, I can just touch it up, and the failures are on the enamel. So they're not between the reinforcing material or the composite. So the nice thing here is that I have the tooth and I can just size it up. I just take it, I find all the extra teeth that I have laying around. I get a shade that matches, and I just take the mesial distal width of it, the incisal edge, and I go ahead and match it up. But very common, you see these endo teeth that just some reason have cast posts or large posts, and they fracture on you. So this is a case that I did. This is a weak post-op. You can see that I replaced this lateral. He had an existing crown on the other side. You can see it's even super-erupted a little bit. But the denture tooth match, the color match is really nice. I mean, it's just to get that chameleon effect that blends right in. So the way I do this, and I'll show you step by step how I do this at the end, is if I don't have the clearance, and many times you don't, I'll place a conservative class 3 in the central. I'll place a conservative class 3 in the cuspid. I'll make a trench across the denture tooth, and I'll lay it across. And I'll just have to use a small preparation on both of those teeth. So you have that, and this has been in the mouth, but I do use a ovate ponic where I embed that into the extraction site. So I go about 2 or 3 millimeters into the extraction site with the logic of that. If I ever have to place an implant down the line, I've got a nice gingival collar and a place where I can place the implant and groom that tissue so it looks like it's naturally growing out of an extraction site or a socket. And this is what it looks like on the lingual view. Look at the gingiva and the response to that denture tooth. If I use the natural tooth, the body would want to reject it. It just attracts a lot more plaque. And then, of course, you've got the acids and the decay. A denture tooth's not going to decay on you. So this looks like it's growing right out of the sockets. This is a completely healed denture tooth. You can tell by the incisal edge of the color that it is a denture tooth. There's a small class 3 in the cuspid, and there's my small class 3 that's in the central, and it works out really well. And here's the x-ray of it. So what you're looking at in the x-ray as you follow the cursor is a really small class 3 on the interproximal, and this nice opaque ball that you see is the composite that I build up in the ridge lap area that I put into the extraction site. It goes in about 2 or 3 millimeters into the extraction site, and I let the tissue heal around it. This is my son-in-law. When my daughter was dating what is now my son-in-law, she said, "Dad, you just got to do something." And he didn't really want to do anything. He's Irish. They have a different mentality when it comes to their dental health. And he was really happy. He played rugby and he does hurling and all these other sports. And he could care less, but she just said to me, I can't be seen with him. So she convinced me to do Invisalign, and he tolerated it for about 6 months. So we created a little bit of space. So what I did is I have the space. I ended up shaving this cuspid tip down, so I had some room when he went into excursions. So right where my cursor is on the top, I just took that tip off, and now this has been in the mouth, and they've been married and together now for 6 years. So this is 6 years old, and I still see him every 2 or 3 days when I go to visit the grandkids. Periosplinting, getting back to periosplinting, there are so many techniques. You look at this, and this is not an ad for Lanap. I mean, I know it looks like it's something you'd see for a laser or periosurgery, but the reality is I found that if I take them out of occlusion and I splint them, that bone fills in. So here's the pre-op. And what I'll do is with the cursor is I will take that completely out of occlusion. I'll allow it to superupt a little bit. I'll make a little trench. I'll fit a little piece of the fiber reinforcing materials into that preparation. And there's the prep. I try not to break the contact. I mean, it's going to be sealed, and I want him to be able to get in there with a proxy brush. So I will prep that and treat this just like one continuous occlusal lesion. If you like flowables, you can place some flowable in the floor if you like to do that. Place your material on it, cover it up, check the occlusion, and 6 months later, the bone just fills right in, and they go from almost 3+ mobility where they're depressible in the socket to having no mobility at all. Patients lose bicuspids. Those teeth fracture, and they typically are non-restorable. Here's a patient who fractured off a upper first bicuspid. She was happy with not putting anything other than just bonding a tooth in. So here you can see the x-ray. There's the bonding material. There's my ridge lap composite that you see. When she smiles, here's the denture tooth. It's been in occlusion now for about 7 or 8 years, and she's happy with it. She's happy with that. And it probably takes about 45 minutes to an hour to do the whole thing at the same time. And there she is when she smiles. So even without being retracted, she's not going to really show anything at all. Here's another case where a patient literally was missing a lower tooth. She had to have a lower molar extracted that was opposing this tooth, and I was afraid it was going to super up. So just for giggles, I made this where I splinted in a denture tooth. I made a molar. I took a molar and reshaped it. And now I have a molar that's in here with the fiber reinforced composite fibers. There's my ridge lap area that was adapted. And when she smiles, here's the tooth here, and it prevents that second molar from superupting into an area where there wasn't a tooth. And at some point, she'll have some lower implants in place, and then it'll be truly in function again. This is one of the few patients I diagnosed with oral cancer. She had cancer of the floor of the mouth, which is seeing, and this is not just the stone. It looks like it's very irregular, but that's actually a skin graft from her forearm. And because of the xerostomia and the follow-up care and everything else like that, she did not want to wear a partial, but she just didn't like the way that gap looked in the front. So I made a model, and I treated it like a denture repair. So what I did is I took 2 denture teeth with pink cold cure acrylic, and I bonded them together. And then I took a piece and I just closed it up and put it into, and now she's happy with it. If you treat a lot of medically compromised patients like Joan and I used to in the past, here's a patient who's terminally ill. He's got stage 4 cancer. And you can see he's got a crown with a clearly fractured root and an active infection. So the oncologist says to me, he's got an active infection. He's complaining of pain. Can we get this tooth out? And then I'm looking at all this crown and bridge thinking, all right, but he doesn't want to walk around with a big hole in his face. But then I noticed out of the corner of my eye, the lateral is an intact tooth that hasn't been crowned. So what I did at the time of surgery is not only was the lateral intact, but it also was in lingual version. So it gave me the way of literally bonding to that entire facial surface. So this is tooth number 10. If you notice on tooth number 10, I've bonded the entire facial surface. I've cantilevered this cuspid. This is a denture tooth. It's now 3 to 5 millimeters into the extraction site. So this is at the time of surgery, and there's the crown behind it. Now here he is about a week later. You can see the healing is there. Here's the lousy plaque control, but there's the bonding that's on it. And this is what it looks like about 6 months later. So you have a patient who doesn't buy green bananas, I was able to build up the facial surface on number 10. And look at how the gingiva just healed around that. It looks like it's a natural tooth and it's growing out of the bone like a natural tooth. This is the lingual version of it. So here's that crown I was telling you about. This is that lingually placed lateral, and you can see how much composite I actually had to bulk up onto that. And what I did is I used the fiber reinforced composite material a little bit. I put a little bit of a class 3 to lock it in on the lingual, and I'm bonding it. And so I've got this sandwiched in on the buccal and lingual. And of course, you can create your anatomy with some really nice burrs and put that together that way. Great case. So this goes back to the early 1990s. And you look at this Padarex, and I want you to focus on 22 through 27. This is just one of those cases you never would have predicted in a million years. She comes back 10 years later. Now look at the lower anteriors. Just she lost all the bone, and they were mobile. They were mobile. So I said, just for giggles, let's splint them together. And now this is a year later. This is a year later. We used a fiber reinforced splint on the lingual surface of 22 to 27, and you can see the bone fill. She went from virtually having nothing, where it was at the apical millimeter of those centrals, to now having about a third of the support. And now this is 2001. This is 2023, Joan. We haven't lost a drop of bone since 2001. And there's the splint. Never had to do a thing to it in almost 20 years. So splinting has its place. It definitely has its place with mobile teeth, and it's not going to grow the bone back, but it certainly can prevent the bone from getting worse. How do you do this stuff? So it's really easy. I buy myself some black polyvinyl material, put it in one of these little guns, and I go into the embrasure space and I just inject this contrasting polyvinyl material. I let it set, then I take a diamond burr and I just blend everything in like that. This way, when I take my micro etcher and I spray the enamel, I'm not going to, really irritate the gingiva. It protects the gingiva, and it makes cleanup so much easier. So when I rinse this off, I put my bonding agent on it and put my splinting material on. It works out really well. Now, I learned the hard way. You don't want to create a bloody mess, so I let the patient do their own blockout now. And when they come in on the treatment plan, there's natural blockout that you can see right there. And what I will do is I will do the splinting first, because I don't want to get caught again in a situation where you clean up their teeth, you have them come back a week or two later after they've healed a little bit, and they start complaining that their teeth weren't loose until I cleaned their teeth. So now what I do is I've learned that I'm not going to loosen their teeth. I'm just going to split their teeth together, and then I take the calculus off at the same time. And it makes it so much easier for both of us. And you can see the calculus is just everywhere. So I let the calculus stabilize the teeth until the splint is in place. And then once they're splinted, I go ahead and I take it up. I see there's a message in the chat room. We'll address that at the end about coding and billing and everything else like that. And it goes back to how much do you want to bill for it? We'll talk about that at the end once I know we haven't run out of time. Look at how thin that is. For orthodontic retention, you don't have that metal bar that the kid plays with it. And then all you have to do is just smooth that off. This stuff is so thin and smooth. And I'm locking it in place on the facial surface. So this is sandwiched in on the labial as well as the lingual surface interproximally, and then it's laid in the cingulum area so that it just blends right in. You can reinforce temporaries. Here's a woman that needed a full upper denture, and we sort of settled on, I'll give some of the material to the dental lab, and they'll lab process a temporary for you, and we'll see how long it lasts. And about 6 years later, she moved to Florida, so I guess it was a success and worked out really well. This is my nephew. This is my nephew who just completed orthodontics. Yes, that is how they left him. It's scary. But this is a diastema that they left him, and they said, go to your uncle and he will close that space for you. The problem is that in the morning after he wore his retainer, the space was smaller, and by the end of the day, the space was bigger. So I said to him, come to me at the end of the day when the space is as big as it is, and I will splint them together and I will bond them. And so I ended up doing that. These are splinted. These are splinted together, and they look really natural. The problem, Joan, is about 2 months later, he was goofing around with his friends and he fractured this one halfway down. and I ended up having to take it out. But because he was only 18, I bonded a denture tooth in that looks exactly like this. So I can't tell if this is, when this was done. I have to find that. I was searching through my database to find that now that replacement tooth that I put in. How do I buy my replacement teeth? eBay. I buy them on eBay. A 1x6 is about $7 now. And the downside is you may have to buy a lot of them, but they're really cheap. They're really cheap. Even if you buy the True Buy teeth from any of your distributors that are out there, a 1x6 is under $10 or $12. So they're not expensive, and you get a great chameleon effect, and you can see you've got an incisal edge, and you could chew them up, and then of course you get a bunch left over when you're done. So let's talk about the mechanics of how I do it. So I'm going to show you on a type-it-out model, step by step, what I've been doing for most of my patients. Here's a patient who's missing a central. Let's imagine that he has an extraction site that is completely healed. So now we have a ridge lap area that's completely healed. In this case, I would find a denture tooth underneath my radiator. Sometimes they get away from you, and it's just not worth looking for it until another day. And when your assistant finds it for you, you put them in a drawer. So here's a denture tooth I found underneath my radiator. And what I do is I grind the ridge lap area. I take a 558 burr, and I literally go in about 2 millimeters to give me some mechanical retention. So I'm not relying on just the bonding liquid. I take good old-fashioned jet monomer, the stuff that you have in your repair kit. It makes me feel better to bond to a denture tooth with a good jet monomer. So I will take jet monomer, wet that surface, put some bonding liquid on it, and then I take my preloaded tip in your syringe, and I stick it in the hole, and I build up an ice cream cone. So I've got this ice cream cone coming out of it, and then I squash the tooth down onto the ridge like you see here, and it'll take on the shape of the ridge. You don't have to put Vaseline. You don't have to put tin foil or some separating barrier or anything else like that. It's skin and it's wet and it's not going to stick to it. So you just go ahead and you squash it down. This happens to be literally as a tooth I found under the radiator for demonstration purposes. You'll probably pick out the appropriate central. But what I do to make life easier is I make a small concavity on the contact area. So it's a track. So if I make a concavity like this on both surfaces, that tooth is stabilized and slides into place and stays there. So what I will do is I will put a little concavity on the mesial and distal, and it has a snug fit. So when I go to try this in, I can literally put it in. I don't have to worry about it falling labial or lingually, and it's lined up perfectly. So I'll take a football-shaped diamond. I'll put a concavity on the mesial, concavity on the distal. I'll make sure it binds a little bit, and I will slide the tooth down into place. Then I take a light and I cure it. I take a light and I cure it from the buccal and from the lingual. And now I will go ahead and I will smooth and polish off any of the flash or any of this excess material that's there. And then I try it back in. And when I'm ready to cement it in or to bond it in place, I take a little bit of material. So I will treat the natural teeth. I'll either micro etch them or I'll use good old fashioned acid etch, and I will acid etch the enamel. Then I'll put my primer or wherever your 1-step or 2-step material is. I will treat the enamel, and then I will go ahead and I will squeeze a little bit of composite on the mesial and distal, and then I'll take my carving instrument, shape it, and then cure it on the labial. Once the labial is cured, I'll take a 558, which is the size that I want, and I will make a small little conservative class 3 on the central, small little conservative class 3 on the other tooth, and I have a track here that I can measure, and I can fit it up and do that to hold it into place. All right, Danik, you're on.
Thank you, Mark. What is DentaPreg? I would say that it's like a perfect combination of different kind of components that are designed to work together as one. What we are using here are aerospace graded fibers with unique mechanical properties. And I would say the key mechanical property here is tensile strength, because this is the way how the structures are typically loaded. Specific design of the fiber reinforcements is further adjusted to the specific indications. Simply put, braided fibers are typically used in the frontal area, and unidirectionally oriented fibers are being used in the lateral area. And this goes hand in hand with the distribution of the forces. And we have a resin matrix, which is designed to protect the individualized fibers, facilitate handling by minimizing shape memory, and to assure compatibility with conventional adhesive systems and resin composites. And third, in this case, invisible but equally important component would be the coupling agents. What we are using is a combination of cold plasma and deposition of silane molecules with long aliphatic chains, and this is the component that allows us to connect together the matrix and the fibers. And after curing, the whole structure behaves like a monoblock.
So it becomes a monoblock, and that's what I like about it. Is, and he'll explain this science a little bit better than I can. It just never debonds. You don't get the same effect that you would with rib-on, that it looks like a wet towel is exposed, or the patient complaining that they can actually feel the matrix material that's embedded in the composite. So as it wears evenly with the composite of your choice because of the chemical nature.
Yeah, so this is actually the reason why is DentaPreg better than other competing materials. What you can see here is a scanning electron microscope picture of the cured composite structure. We are using special technological processes of surface treatment of fibers and controlled uniform impregnation by resin matrix. This simply means that all the fibers in the structure are perfectly covered with the matrix. Thanks to that effect, the stresses can be effectively transferred from the resin to the reinforcing fibers. And what you can see on the upper picture is like a monoblock structure of our materials. What you can see on the lower picture, however, is a composite structure that doesn't work as effectively, because what you can see there are some gaps and voids which are associated with adhesive failures. And in this case, it would never be possible that the stress will be transferred from the matrix to the fibers effectively. Ultimately, these gaps and voids are the areas where the stress is concentrated and when the potential failure will start.
Okay, so that pretty much sums it up. I see that there's one question in the chat room, and I hope that it was enough to explain that. I've done some heroic cases. I literally have replaced 2, 3, and 4 teeth in the anterior. I'll start off with an excess. I'll take out the teeth at the time of surgery. I'll make an Essex type retainer, and I'll put that in the mouth with the denture teeth inside the retainer. I'll let it completely heal so I can check the healing over time. And then what I'll do is I will peel back the labial surface. I'll tack the teeth in place, and then I'll take some reinforcing material and go from bicuspid to second bicuspid to second bicuspid to really give me a perio splint that goes in many cases from 4 to 13. I thank you very much. There are competitors out there, according to what I've heard from Danik and his other partners at the company, is that their bonding system, the way it's cured to the fibers, there are no voids, there are no gaps, and it's just the strongest material that you can get by doing it. And there are ways to do adhesive bridges, splints, retainers. They have these little cubes that will reinforce the dentin that you're doing if you're doing a large restoration where they have fibers built into it at the same time. There's a code here that's Dr. G23, and then they have an online shop. Certainly my contact information, I will go back. So there's my contact information if you need it. All right, so denture codes. So what do I charge? The question comes up, what do you charge? And it goes back to a lot of these patients, it may be considered a temporary measure. And you got to think of how long it's going to take you. So it takes me about an hour. It takes me about an hour from start to finish, and I'm doing the extraction at the time. So you get the extraction fee. You get the extraction fee, whatever the extraction fee is going to be. And then because I'm doing a class 3 composite on the adjacent teeth on either side, I bill it as 2332 or 2335, depending on how many surfaces there are. And I submit that to the insurance company. If it's an out-of-pocket procedure, depending on how long it took me to do it, I typically charge between $600 and $800. The warranty is good for about 3 to 6 months, but the few times that they fail, I tell them that when you're looking at this, you have a plastic tooth in your mouth. It would be no different than if you had any other type of dentistry done or an eyeglass screw holding an implant in. I tell them they need to cut their food with a knife and fork. If they can cut their food simply with a knife and fork, it's pretty safe to eat it. But the few failures I have, they did it. They did it on their own, and they'll admit it that they were biting on something they shouldn't have. So there are resin bonded bridge codes that you can do, and there are abutments now that you can look up and do that. It says you mentioned that you place some jet liquid on the underside of the denture tooth and then placing is this directly over the wet jet? Well, the jet liquid that I place, like you would, it's a monomer. It's almost like a prep solution that evaporates over time. So what I do is I take the jet liquid and I put it on the denture tooth and I let it evaporate, and then I use my bonding system on it. Really doesn't matter. I haven't found one bonding system to be better than the other. I'm thinking, Joan, she had juvenile periodontosis. She was really young when she came to me. It affected the molars as well. And so we splinted them, and it probably between the home care, the splint, and like juvenile periodontosis, it burnt itself out after about 10 years. Have you ever used silk reinforcement? I bought a roll at a nail salon. I mean, you could pretty much use anything. The problem with using straight composite, it's just too brittle. It won't torque and it won't twist. So I think that if you bought the silk material that's there, it would probably over time be no different than Ribond, and it would wear through, or you'd have a problem with that. The other problem is that if the insurance company found out you were using silk or other material that's not FDA approved, they may end up having a problem with that. There were a couple of dentists, Joan, if you remember, that thought that paper clips were as good as a Parapost. I see. You remember that case, right? There are dentists that saved themselves a fortune by using paper clips instead of because I mean technically they're the same thing. But then, when we're using metal posts, you could take a paper clip. And then what happened is he was billing out $150 for a post and core. And I guess his dental assistant got pissed off at him one day and called Medicare, or not Medicare, Medicaid, or whoever the insurance company was, and said he's using paper clips. He's not even buying FDA approved devices. But, I found that you can buy a lot of stuff online at a fraction of the cost. When I talk, this is part one. I've got part two about Dentapreg has another unique product called Pin Post. So when I'm doing my post and core buildups, they look like little tiny fiber needles. They're composite needles. So when you get that oval canal, or you get that canal where a post is just going to swim in it, what I'll do is I'll have one large main composite post, and I'll take these little tiny pin posts, dip them in the cement, and then I'll put my composite around it. They just last. I mean, they're solid. They flex like dentin, and they're just beautiful. They're just beautiful to build these things up. So I had a case where one of my patients went to another dentist that sent him to an endodontist on a bicuspid, and then they send me the final X-ray, and the patient says to me, "Well, what do I need to do?" I said, "You just can use that tooth for reading." And they said to me, "I don't get it." I said, "That tooth is so hollow and weak, it's basically useless now." And so I called up the dentist and I said, "Look, how are you gonna restore this tooth?" He said, "I'm gonna just put core buildup in." I said, "You can't squeeze core buildup in a hollow endo tooth. You gotta do something like use a composite post." He says, I don't have them." I said, "I'll tell you what, I've got them left." I was willing to send him the composite post, send him the pin post. And he said, "All right, I'll cancel the patient and I'll wait till you send me the stuff." I get a call from the patient a couple of days later. He said, "I'm done." I said, "What do you mean you're done?" "I never sent the stuff." He said, "I was there." He said he spoke to you and he just wanted to fill the hole. Um, all right, so how many teeth would you consider replacing in the mandible area? It really is dependent on occlusion. It depends on the occlusion and the space and the patient's habits. So, so when it comes to, I have done two. I have done lower molars without a problem, but it's like anything else. When you're doing a lower molar, You want to make sure that you have a little bit of a gap between that so that you can prevent the opposing tooth from super-erupting, but at the same time, there's less pressure on that plastic tooth than there is on the natural tooth. You try to get the occlusal forces on the natural tooth. But I have done 2 on the lower. I've done 2 and 3 on the upper, and that's where I've gone with this. But I have used Essex, and I guess an Essex retainer and bonding something if you're allowing healing to occur. But if you have to do it over, it's not the end of the world because you really haven't done anything that's going to really cause any real preparation or damage to the adjacent teeth. What if you have crowns on each side of the replacement tooth? That's a problem. You know, I've evolved at the end of my practice where I will actually prep crowns. I will put a class 3. I've had cases, and I'm sure, Joan, you've seen this as well, where you get a patient that has recurrent decay under a distal or mesial margin of an existing crown. You can't get access to it. So and they can't afford a new crown. In the perfect world, it'd be nice to say, let's make you a new crown. But the reality is that you'll never get paid for it. So I'll take a diamond burr and I'll put a class 2 prep in an existing crown. I've got a lot of cases where I've done that, and I'll fill that and get to the decay. Same thing on an existing crown. If I have existing crowns on either side and it turns out that I believe that this is a good temporary or permanent solution, I have prepped them and done class 3s in existing crowns and tried to mechanically lock it in as well. It's not as good as enamel. I'm not going to kid you and say it is. It's just not the same as trying to work with natural enamel. All right, any other questions? Well, this is part 1, I hope, of an evolving program that I can continue to use. I've got so many cases, I thought that it would be about an hour, and I think that's about our attention span because it's a Wednesday night and it's simple. This is not rocket science, even though the material is made by a rocket scientist. It doesn't really take a PhD to understand how to apply this in your practice and see the implications for you. And I hope it was something that you got something out. My goal is to learn something every day, and I just hope that I could pass it along and that you got something to improve the way you practice and grow your practice as well. Spread the word. I'm thinking that maybe in a month or so, I'll just do this again. I'll add a couple more cases and slides to fill out the time. This is version 1.0, and version 1.2 should be a lot better. But thank you, everybody. Thank you, everybody, and good night.
Thanks again.
Thank you.
Have a great day today and every day.